Good morning, everyone. I'm going to share my screen now, and we can get started. Can you see my screen okay? Great. Okay, welcome, everyone. Today, I'll be talking about principles of medication use in older people, a very important topic. So these are today's learning objectives. I'm going to be talking about key issues in geriatric pharmacology, effects of age on pharmacodynamics and pharmacokinetics. I will explain what these terms are. I'll talk about risk factors for adverse drug events and drug-drug and drug-disease interactions, and then end with some good principles of prescribing for older people. So just to start out with aging, there are over 45 million people 65 years and older in the US, and this is 15 to close to 16% of the population by now. But this small group of patients uses a disproportionate use of medications. So over 33% of prescription drugs are used by the people over the age of 65 and older. Most older people, over 90%, take at least one medication. And polypharmacy, which is also using multiple medications, is actually quite common. So this graph shows you prescription drug use by age. So here, this is children, 0 to 11 years of age, 12 to 19. And then these are adults and middle-aged people, 20 to 59. And this last group is 60 and over. And this first bar in dark blue is one drug. And then as we get over, it gets to 2, 3 to 4, and then 5 or more. So I want you to focus on this light green bar. So you can see among the younger age groups, there are not too many people who have multiple medications. But once we get to people over the age of 60, over 1/3, 36.7% of people are taking 5 or more medications. So you can see this problem of polypharmacy, taking multiple drugs, is mostly seen in older people. Now, why is this? So one is, as you get older, you get more illnesses. And of course, as each illness happens, more and more medications get added. A lot of older people are seeing multiple doctors, many specialists. And sometimes there's lack of communication between the specialists. Sometimes I've even seen this happen. I know this is kind of scary, but I've seen a patient take the same medication just under 2 different names. One was under a trade name, one was under a generic name from 2 different doctors. So I think communication between the doctors is really important. I always recommend to my patients, really the primary care doctor should be the captain of the ship. So if you're going to specialists, you should still make sure that your primary care doctor knows what the specialists are recommending. The other issue is that over-the-counter medications are really easy to get and very common. And often people will think they're safe, but they may not be quite so safe. Shared medications is also common with aging. We have a lot of very well-meaning older people. You know, they're talking to their neighbor and the neighbor says, oh, I'm having trouble sleeping. And they say, here, you want to take some of my sleeping pills. And they mean well, but really that's not a good thing to do. And then nutraceuticals, which is the herbal medications. Those are very, very commonly used. And people sometimes think because they're plant-based that they might be very safe, but that again is not always the case. A very potent heart medication, digitalis, is actually from a plant. It's from the foxglove plant, and it can be extremely dangerous if you're not taking it correctly. So again, just because it's from a plant doesn't mean it's necessarily safe. So what are the consequences then of taking these multiple medications? Obviously, the more things you're taking, the more likely you are to have drug interactions and also side effects. And we see that medications are correlated with these geriatric syndromes, cognitive or memory problems, falls and injuries, incontinence. If somebody suddenly develops incontinence and they also started a new medication at the same time, Until proven otherwise, I'm suspecting that new medication and testing that out. And then sometimes we just see this sort of decline in functional status where they're sort of dwindling and not having anything specific, but just doing worse and worse, or losing weight, or just not able to function as well. And again, we want to avoid these problems due to medications. Now, compliance can be an issue at every age. To be honest, it's more likely in younger people to have poor compliance. Older people are more likely to actually listen to their doctors and actually take their medications as instructed. But we do know that there are certain risk factors. So if the medication regimen is extremely complicated, we know that people are less likely to be able to follow that. And I can sympathize with that. You know, when I'm given a medication that I have to take 3 or 4 times a day, it's very unlikely I'm going to remember every single dose. I'm going to forget some. So more simple is always better. Cost can be a huge issue as well. Some medications can be dreadfully expensive. That's one thing I think most physicians, including myself, we're not very good at knowing how much medications cost. So I always let my patients know if any of the medications are too expensive, please let me know and we'll talk about it, and we can talk about alternatives sometimes. Some conditions are asymptomatic. A common example is high blood pressure. Patients who have high blood pressure have absolutely no symptoms in the early stages. And so they might think, why should I bother to take a medication when I'm not having any problems? Well, you're taking it to prevent problems down the road. So again, a lot of education helps with that. This is a very alarming, these are alarming data that we see. So this is basically looking at the percentage of people who are prescribed a medication. So let's say we're looking at everybody who's given a prescription. Okay, that starts at 100%. Then we go to see how many patients actually fill that prescription. We're already 12% have not filled their prescription. So now we're down to 88. Okay, you filled your prescription. Now, are you taking your medications? Again, 12% haven't taken their medications, down to 76%. And then we look to see, did they actually continue their medications? Again, we see a massive drop-off. We see actually drug compliance is less than half. And this study showed that actually 22% of patients take less of their medication than is prescribed. So we want to be sure that we address this issue, because of course, if you're not taking the medication, it's not going to be helping you. There are some specific issues related to aging. One is poor vision. Those labels have teeny tiny writing. Can your patient even read the label? If they cannot, the pharmacy can give you large print labels that are specially made, but you have to ask for them. The other one is poor hearing. Did people hear the instructions? I think this is particularly important here in Hawaii because people in Hawaii are so polite. So if their doctor's talking to them about their medications, they're going to smile and nod. And the doctor thinks, oh yeah, they heard everything. Maybe they didn't hear anything. So it's important for me to ask people, okay, tell me what you think I said. So I can make sure that they actually heard me, they understood me well. Memory problems, can people remember? If they're having significant memory problems, they may not even be able to remember when they have to take medications. Now, sometimes a Mediset, where you have a little pill box, can help. But in order to use that pill box correctly, your memory has to be good enough that at least you know what day it is and what time of day it is. If you're so confused and your memory is so bad that you don't even remember that, the pill box is not going to work. You need somebody to actually supervise the medications. Arthritis. If people have arthritis in their hands, sometimes these childproof caps make it very hard to open the bottle. Swallowing problems. Some pills are huge and patients may have really big trouble swallowing them. So we have to, again, anytime you have trouble with your medications, let your doctor know. Next, I want to talk about this medical student Tic-Tac exercise that one of my faculty came up with. So this was a really cool idea. We have our medical students at the John A. Burns School of Medicine. All of them have to go through 1 month of geriatrics and palliative care with us, no matter which specialty they're going into. So even if they're going into surgery or orthopedics or urology or ophthalmology, doesn't matter. They're all going through this. And we want to teach them how to use medications correctly in older people. So this exercise is to show them how hard it is to follow a complicated medication regimen. So we use these different colored Tic-Tacs, and each Tic-Tac is supposed to represent one medication. And we actually have pill boxes that were donated to us by our pharmacy with the labels written in. And we give these students the medication bottles with instructions, and we tell them, take it for a week, and then bring it back next week. And then we ask them, how did you do? And then we also count to see if any pills were left. If they took the pills as instructed, there should be nothing left. And what we see is they are not able to do it. So it really makes them more empathetic towards their patient when they're prescribing medications. So next I'll move on to this concept of pharmacodynamics. What this means is the effect that the drug has on the body. So it's a complicated and long name, but basically it's just what effect does a medication have on the body. What we know is at the same blood concentration, older people are more sensitive to the effects of drugs than younger people are. And this is particularly true for the brain. We know there are some changes in the brain even with normal aging. One of those changes is decrease in neurotransmitters. These are the chemicals that send messages between the brain cells. And even with normal aging, with no disease, we know that these are lower in older people. There's also a barrier between the blood and the brain. So every medication that you take doesn't rush up into your brain immediately. Your body has this natural barrier that avoids medications going into the brain. But again, with aging, we know that this barrier is not as good. So more medications are going to go into the brain in an older person compared to the younger person. And this is even more true when people have neurologic diseases, which are also more common in old age. These are diseases like Parkinson's disease, stroke, Alzheimer's disease, other types of dementias. They're definitely more common in older age, and they alter this blood-brain barrier. So an older person, first of all, more of the drug is going to get into their brain even under normal circumstances. And if they have a neurologic disease, a brain disease, even more so, these drugs are going to concentrate in the brain. So you can imagine why more side effects are seen, more confusion, or more other side effects due to the neurological changes. Pharmacokinetics is again a big name, but it's just what the body does to the drug. So once the drug gets into the body, what happens to it? That's called pharmacokinetics. And it's divided into 5 things: absorption, distribution, protein binding, metabolism, and excretion. And I'll go through each one of these. So most medications are given by mouth. You take them in a pill or in a liquid, but you swallow them, most medications. So the amount that's absorbed is usually unchanged with older age. Older people who don't have problems with their gastrointestinal tract, so they don't have disease of their stomach or their intestines, they will absorb medications very well. But this absorption may be a little bit delayed. So I'll give you an example. One example may be sleeping medications. So maybe a doctor gives the patient sleeping medications and they take it right before they go to bed. But then they notice that, oh, it's taking me 2 hours to fall asleep. So they tell the doctor, oh, this medication's not working. So what does the doctor do? They raise the dose. Well, I suggest instead of doing that, maybe they should give it a little bit earlier, because it could just be that it's delayed absorption. And if you give it earlier, it will get absorbed and the patient will still have the effect. I always try and keep the dose as low as possible in older patients. So a lot of things affect absorption, depends on what else is taken with it, whether it's taken with or without food. What is the acidity level of the stomach? How well does the stomach move? Are there any illnesses? So again, talk to your pharmacist. If you're not sure, should you take it with food? Should you take it before or after meals? How much liquid should you take with it? All of these instructions are important. Intravenous medications, there's really no difference in aging. Intravenous medications reach the bloodstream quickly, no matter how old you are. But intramuscular medications, this is shots that are given into your muscle. These may be erratic, so we can see highs and lows that we may not be able to predict. Now, some things we have to take by shot. For example, the COVID shot. That's the only alternative, right, for that vaccination. And most vaccinations are like that. Your flu shot, you should be taking it through your muscle. But certain medications, sometimes we try and avoid giving them intramuscular in older people because this absorption is erratic. Don't forget that medications can be absorbed through the skin and even through the eye. So sometimes even eye drops that are given to people for glaucoma or other conditions may have an effect on other things like the brain. I've seen people who take certain glaucoma medications actually get confused because so much of it is being absorbed. Same thing with the skin. With aging, the skin is thinner and it breaks easier. You see little skin tears much more commonly in old age. So again, any ointment that you're using, the absorption could be quite high in older people compared to younger. Now, distribution, once the drug gets into the body, it's distributed around the body. Body weight actually starts going down after the age of 65. So people think, oh, that's wonderful, I'm going to be losing fat, right? Actually, no. The reason body weight starts going down is because lean body mass goes down. So what you're losing after age 65 is you're losing muscle, bone, and even water. Many older people are slightly dehydrated even at baseline. So even though weight is going down, percentage of body fat is actually going up with age. So with this increase in total body fat, certain medications that are actually soluble into lipids or fats, now there's this huge fat pool that's waiting to trap these medications and hold on to them. So we see these types of medications, which is most medications are lipid soluble or fat soluble. We see that they hang around in the body longer. That means the effect is going to be there for much longer for many of these medications. We also see a decrease in total body water. So certain medications like water-soluble drugs, one good example of that is alcohol. Now we see higher peaks. Think about it. If there's less body water, it's like the bucket is half empty. Now you're putting the same amount of medication into a half empty bucket. Of course, the concentration is going to be much higher, right? So I've had patients tell me I can have 2 drinks and it has no effect on me. I've been doing it all my life. Well, maybe they've been doing it all their life, but now they've reached the age of 80. And now, because they have this decrease in total body water, suddenly the alcohol level is going to be higher if they drink the same amount of drinks. So we always recommend that amount that people drink gets less when they get older, because we don't want these higher peaks. Protein binding. Many proteins in the blood actually bind to the medications. Even in normal aging, we see decreases in certain proteins, and even more so when people have malnutrition. So what that means is less of the drug is bound, which means more of the drug is unbound or active. Again, what does this lead to? Higher side effects. Blood drug levels can be very misleading because they actually measure total level, not active drug level. So again, this is something we teach our students. Don't be fooled by the level. I always say, listen to the patient, not to the number. Even if the drug level seems normal, but if the patient is reporting side effects, I'm assuming that that's because of that medication. As the drug goes through the body, there are chemical changes that are made to the drug. And this is most commonly done in the liver. It's actually kind of deactivated. So most medications, as they go through the liver, they're deactivated. Aging does cause a decrease in liver blood flow, size, and function. So certain drugs can take longer to be broken down. Certain other conditions like congestive heart failure can also worsen liver function and can again delay the drugs being broken down. So you see this pattern, right? The drugs are going to hang around in the body longer, causing more side effects. Excretion is getting rid of the drug from the body. So we get it out of the body. Most drugs, this is done by the kidney. And we do know that aging causes decrease in kidney size, blood flow, and function as well. We also know that kidney diseases are more common with aging. This is particularly true for people who've had high blood pressure and diabetes for many years. We know that their kidneys don't work as well. So again, when the body is not getting rid of the drug, it causes drug accumulation and toxicity. Half-life is a term that's defined for the time that it takes for a drug to drop in concentration by half. So I have a drawing of that, okay? So this is a very complicated drawing, but it's really not that hard to understand. So I'm going to point it out. So here on this axis, we have time. This is 0 to 1 half-life, 2, 3, 4, 5, and 6 half-lives, okay? And on this axis here, we have the percent concentration of a medication. So this is the highest concentration. When you first take the medication, it's fully concentrated in your blood. It takes 1 half-life to drop to half. So now it's gone from 100% to 50%. At the second half-life, you again drop by half. So now it goes from 50 to 25. Again by half, you see it goes from 25 to 12.5. You get the picture, right? Each half-life, it drops by half and half and half. So in order to get a drug out of your system almost completely, it takes about 5 half-lives, where you see at this point, there's less than 5% of the drug left in your system. So it's almost gone. There's very little bit left. So I'll give you an example of a medication called Valium, a very common medication used for sleep. In young adults, the half-life is about 24 hours. This is a long-acting medication. So it lasts for about 24 hours. That's the half-life. In old adults, it's 4 times as much. It's about 100 hours. So now multiply that 100 hours or 4 days by 5 half-lives. We're now talking about 20 days before that drug is mostly out of your system, which is why I never use this medication in older people, because once you give it, you cannot take it away. You just have to wait for time for it to kind of the body to get rid of it. And it takes too long. So any of these medications that last for a very long time, we try and avoid these long-acting medications in older people. It also takes longer to get to what we call steady state. So this red is a young person. So they take a medication, their level goes up, then it goes down again, then they take it again and goes up and down and take it again and again. And finally, they reach what we call steady state. This is an older person, the one in green, and you can see it takes longer to get to steady state. What does this mean? Don't give up on a medication too soon, because it may take longer to see the effects, the good effects of a medication as well. So then, given all of these changes with aging, what is successful drug therapy? We want the right dose of the right drug for the right condition and the right patient. So we want to hit this bullseye on all of those. And failure in any of these can lead to adverse drug events. Unfortunately, adverse drug events are very common in the United States. They're responsible for 700,000 ER visits each year and 120,000 hospitalizations each year. That is alarming, right? There's a lot of money spent because of adverse drug events, but even more than that, think about the human toll. Nobody wants to be rushed to the ER or put into the hospital because they're having medication side effects. The sad thing is many of these are prevented. So we really need to work hard. And we know that our older patients are more prone to these adverse drug events. So we really need to work hard to protect our frailest older patients from these problems. These are the risk factors for adverse drug events. The first one is advanced age. The second one is high number of medications. This could be prescription medications or even over-the-counter medications or even herbal medications. So the more of these that you take, the more likely you are that there will be an adverse drug event. If there was a prior adverse drug event for that medication or for even one in the class, the same class of medications, that means you're at higher risk again in the future. Use of alcohol or even other drugs, especially illegal drugs, can be a huge risk factor. Low body weight, this is a big problem, particularly, here in Hawaii. I think some of our Asian ladies in particular, their baseline weight is like 90 pounds. So obviously their bodies are small, they're going to be at higher risk for these drug events as well. And then, of course, poor liver or kidney function, because we know the liver breaks down the medication and the kidney gets rid of the medication. So if the liver and the kidney are not working well, the drug accumulates in your system. This is a prescribing cascade that I don't like to see. You give the first drug, there's an adverse drug event. This is misinterpreted by the doctor as a new medical condition. So what do? They add another drug. You have another effect. Another drug gets added. You keep adding and adding and adding, and you get into this vicious cycle. My suggestion is, if you start a drug and you see an adverse drug effect, maybe cut back on the dose or maybe even stop taking the drug. Again, always do this with your physician's advice, but maybe that's the key rather than adding a new drug every time there's a new symptom. There's this thing called drug-drug interactions, where if you take two drugs at the same time, they interact with each other and either cancel the effects out or make it more toxic. So either way is not good, right? Because one way you're losing the effectiveness and the other way you're getting toxicity. So both are bad. These are common and they're more likely the more medications you're taking. They can also affect the absorption and metabolism of other medications as well. They can exaggerate or diminish the effects of medications. Herbal and over-the-counter medications are notorious for this. In fact, there are certain herbal medications that interfere with anesthesia to the point where, you can have serious side effects from anesthesia if you're taking those herbal medications. When they first came out, people didn't know about these, but now the anesthesiologists do. And so they ask about all medications before you go to surgery so that they know and they can tell you which ones need to be stopped. There's also drug-disease interactions. Obesity can alter the amount of fat in your body. And so it can alter the volume of distribution of medications. Again, an obese person has a larger fat reservoir. It's going to hold on to the drugs longer. Dementia, particularly Alzheimer's disease, can increase sensitivity or even induce these paradoxical reactions to certain drugs. So for example, dementia is this, Alzheimer's disease is this condition where there's a chemical that's low in the brain. It's called acetylcholine. It's actually the memory chemical. And the levels are lower in the brain of people with Alzheimer's disease. If you give certain drugs that are what we call anticholinergics, a common example is Benadryl. Everybody knows what Benadryl is, right? Sometimes you take it when you have a rash or itching or for other reasons. Well, this actually makes the level of acetylcholine go even lower. So now you can imagine you have a patient with Alzheimer's. Their brain chemical is already low. Now you're giving them a drug that's going to lower it even more. Instead of making people sleepy, Benadryl usually makes people sleepy. It can make a person with Alzheimer's go completely crazy because it's having this paradoxical reaction. Often these Benadryl or the active ingredient of Benadryl is hidden in certain cough and cold medications or certain sleep medications. So patients may not even realize they're taking it. It's over the counter. They assume, of course, it must be safe. And they have this really bad interaction. Again, liver and kidney disease can be a real problem as well. I want to talk a little bit about this thing called Beer's criteria. It has nothing to do with beer, by the way. It was named after Dr. Beers, who created this first checklist. It was originally published in 1991, and he made a list of what he called potentially inappropriate medications that are best avoided for older patients, because most of the time, the risk is greater than the benefit for these medications. And since then, there have been multiple updates of these Beer's criteria. I think the latest one was done in 2019. The intent of these Beer's criteria is for use in adults over the age of 65 in all settings, in the clinic, in the hospital, in the nursing home, but not intended for use for hospice and palliative care patients. Because especially for patients in hospice or even those receiving palliative care, the goal is really comfort. And sometimes we use these medications that we know may have certain effects because really the goal is to keep that patient as comfortable as possible. These criteria help doctors improve medication selection, and they give good education to both doctors and patients, and also reduce adverse drug events. They've done studies to show that quality of care, cost of care, and patterns of drug use are much better in older people when we use these Beer's criteria. So now many of the hospitals around the country have even incorporated them into the computer systems, the electronic health records that they use. So if I type in a certain medication for my patient and my patient is over 65 years old, the computer gives me a little warning. It doesn't say you cannot prescribe it. It allows you to prescribe what you want to prescribe, but it'll give you a warning to say, by the way, this is a high-risk medication for older patients. Are you sure you want to use this? Or would you like to try something different? So it's kind of tipping off the doctor to say, I at least need to think about this and not just give this medication to my older, frail patient. This other group came up with something different. They said the Beers criteria are good for stopping potentially inappropriate medications. But what about not having the right medications prescribed? So what they're trying to do is balance both. They're saying we should stop medications that are dangerous to older people, but we should start medications that should have been prescribed and didn't get prescribed just because of age. There are some common examples for that. We know, for example, depression in older people is massively undertreated. It's not recognized well, and then it's also not treated well. So not only do we stop the inappropriate medications, but we start the appropriate medications. And these criteria were demonstrated to improve medication appropriateness, both in the hospital and also after discharge, and also to reduce adverse drug events and length of stay in the hospital. So I'll end then with some rules for drug use in the elderly. These are some rules that we really go by every day. One is, for most older patients and for most medications, we start low and we go slow. So we don't make sudden changes. We do that very slowly. Another thing is we always assess the risk versus the benefit. Everything has risk, even taking something like Tylenol, which is safe. It is a relatively safe medication, but it's not zero risk. There's nothing you put in your body that has zero risk. So you always want to weigh that. What is the risk? What is the benefit? You have to be sure the benefit is greater than the risk. The other rule is don't quit too soon. Remember, I showed you that graph that said it takes longer to reach what we call steady state. So longer to see the true effect of the medication. So in geriatrics, we have to be patient. We try things and then we have to wait to see if they are going to work. We also monitor very closely for side effects because we know they're going to be more common in an older person. I like to avoid starting 2 drugs at the same time. Now, sometimes that's impossible. If somebody comes into the hospital and they're really sick and they have lots of things going around, often we have to start 2, 3, 5, 10 drugs at the same time. But I'm talking about if somebody's stable, I'd avoid starting 2 medications at the same time, because if I did both at the same time and they have a side effect, I'm not sure which one caused it. So I'd rather go slower and give one first, see how they do, and then start another one if I need to. And then this last one is actually my own personal rule, my roller coaster rule. So my family and I, all of us, we love roller coasters. We love these crazy kind, particularly my daughter and I love these crazy kind that kind of fling you all over the place. Many years ago, when my husband and I were young, we decided we'll never go on a roller coaster in the first year that it opens, because that's usually when a lot of the problems come up, right? And then after that, they fix the problems and then it's always safer. We have broken that rule. We've been tempted sometimes and we've broken that rule. But I use that same rule for my patients. If a brand new drug comes out, I think twice and 3 and 4 and 5 times before I'll start that new medication in my older frail patient. Because again, when a new medication comes out, you're not sure about all the side effects. It takes a while before lots of side effects are reported, and then we know what the true side effect profile is. Now, have I broken that rule? Yes, I have. For example, when the first Alzheimer drug came out, of course, I wanted to try it because there was nothing else. So if there are no other alternatives, of course, I'm going to try it, but very cautiously. Unfortunately, most of the Alzheimer's drugs haven't panned out yet. So now I'm less enthusiastic about them than I was when they first came out, but I was more enthusiastic about trying them then. But if a new medication came out for diabetes or for high blood pressure, and I know there are other effective medications out there that have been used in older people safely for many years, I'll probably use those older medications and wait until the newer medication gets a safety track record. So I think we need to ask ourselves these questions. Is the medication necessary? What are the goals and endpoints? They're not the same always in older patients as they are in younger patients. So in some of my older patients, particularly those who might be falling a lot or are quite frail, I don't want to drive the blood pressure as low as I would if somebody was 40 years old. If somebody's 40, I want to bring their blood pressure down to the normal range. In somebody who's 80 and frail, I might be okay with the blood pressure being a little bit higher because actually dropping the blood pressure too low might have its own side effects. Always ask, are the benefits more than the risks? Are you treating the effects of another drug? I really prefer not to do that if I can help it. Can one drug be used for two conditions? And are there drug or disease interactions? For the drug-drug interactions, there are wonderful computer programs now. So usually I'll call my pharmacist friends and I'll tell them, could you, because no physician, no human being can remember all of them. It's impossible. But the computer is really good at picking these up. So I'll usually call a pharmacist and say, hey, this is my patient's list of medications. This is what I want to add. Can you just run it through the program and see if there's any potential drug interactions? These are some good habits for doctors. Does your patient know what each medication is for, how to take it, and possible side effects? Not only talk to people, but give them written instructions because they may not remember what you told them. Simplify medication regimens. I really like the Mediset, so it looks something like this. There are different versions of it, but there's Monday to Saturday here, and then usually there's 4 boxes for breakfast, lunch, dinner, and bedtime. And then each of these you can put pills in. Again, make sure that the person's memory is good enough that they know the day of the week and what time of day. Otherwise, the Mediset doesn't work. But for somebody whose memory is intact, who has trouble opening the boxes or figuring out what to take when, a son or daughter or even a visiting nurse could come in and fill the Mediset for the week so that the patient can still be independent. Avoid these high-risk medications, which we know can really cause problems in older people. At each visit, I use a sophisticated method called the brown bag method, which is I just tell my patients, please put everything you're taking or everything in your house into a brown bag and bring it for me to see. And do a thorough medication review, including over-the-counter medications, herbal medications, vitamins, eye drops, ointments, all of these. Home visits can be very useful. I've gone to home visits and with the patient's permission, I ask, may I look in your medication cabinet? Can I look in your fridge? Because often people will leave their meds in their fridge or by your bedside table or your bathroom, wherever they're storing their medications. Please, can I look? And if they could give me permission, I look. And sometimes I find things that are really dangerous, like they have an antibiotic that they took 20 years ago and they still have saving the leftovers. And that can be really dangerous. And again, with their permission, I will get rid of those dangerous medications so nobody takes it by accident. So in summary then, successful prescribing means selecting the right drug at the right dose for the right condition and taking into account the individual patient and their own goals of care. So the other day I was in the hospital and I saw these 2 doctors talking. The first one said, what exactly does a geriatrics consultant do? And the second one said, not much. They just stop half the medications and cut the doses of the rest. So the first one says, anybody could do that. And the second one says, the trick is figuring out which half. So with that, I'm going to stop my share screen and get you all back on the screen. And thank you for your attention. And please let me know if you have any questions. Anyone have any questions? No questions at all? Looks like we're getting a question. No? No, okay. Okay, well then, thank you all for your attention. It's been very nice talking to you. I think this is the third talk we've done, and I hope you've enjoyed them. And I know that this one at least was recorded. I think the first one wasn't recorded, but the second one and this one were recorded. So if anybody knows of people who might be interested, then Michaela will give the recording to Pilahi, or at least the link, so that you can tell your family and friends they are welcome to watch it if they'd like to. Okay. And thank you again for inviting me to do this. I really appreciate it. All of you, please take care and have a happy holidays. Bye-bye.